In this video, I'll be teaching you everything that you need to know about heart sounds and heart murmurs. This is an incredibly high-yield topic that for many years now, I've been trying to come up with a good way to explain this. It's very complex, and actually getting this information in your brain will yield so many points on test day, because on USMLE and Comlex, a lot of the ways that test writers will go after heart sounds and heart murmurs is that they'll actually give you either a visual depiction of the amplitude of sound, or they'll give you an audio file on your question or on your exam, and you'll have to listen to that heart sound in order to get the question right. So there's absolutely no way that you can get these correct on your test unless you thoroughly understand heart sounds and heart murmurs. And this is both visually but also acoustically. So in this video, I'm going to give you all of the knowledge that you need in order to dominate these questions. In this video, this is what we're going to be talking about. We'll start with just talking about what normal heart sounds sound like. And the reason for that is because you can't detect abnormal unless you know what's normal. So we'll talk about normal heart sounds, and then we'll go into splitting of heart sounds. Specifically, we'll be talking about S1 and S2. And then we'll go through the actual high-yield murmurs. So we'll talk about aortic stenosis, mitral and tricuspid regurgitation, mitral valve prolapse, ventricular septal defect, aortic regurgitation, mitral stenosis, and a patent ductus arteriosus. So let's begin by talking about normal heart sounds. And I'll actually play for you what normal heart sounds truly sound like. So you're going to hear real audio in a few moments. But first, let me just explain. So when you're taking your exam, what you might see is something that looks like this. And this is just a visual depiction of the amplitude of sound. So if you've ever gone online and listened to music on a website like SoundCloud or something similar, you've probably noticed that you see this sort of waveform of amplitudes, and that just represents how loud is sound that you're hearing. And just like that occurs on websites where you listen to music, it's going to show up on your exams when you're taking USMLE or Comlex or in-class exams when they're trying to give you questions about heart sounds. So when we talk about normal heart sounds, and again, the track of the audio file of what this actually sounds like is coming, so just bear with me. When we talk about normal heart sounds, we're talking about an S1 and an S2. So close your eyes. Imagine any movie or TV show where you've heard a dramatic heartbeat in what you're watching. You know that there are two distinct sounds of a heartbeat, right? Boom, 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 boom. There's two bums, and if we're being a little bit more scientifically accurate, we would say there's a lub followed by a dub. So instead of boom, 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 when we talk about normal heart sounds, it would be more correct to say lub dub, lub dub, lub dub, lub dub. Now the lub, or the first heart sound in a normal heart sound, is your S1, and the dub, or the second heart sound in your normal heart sound, is an S2. And if you look at the cardiac cycle graph, and relax, I know that you're getting overwhelmed here, but we don't need to know this for the heart murmurs section. But if you look at the cardiac cycle here, what we see is that the S1 heart sound occurs just at the beginning of systole. So that S1 heart sound occurs during the isovolumetric contraction, right? The mitral valve closes, and the tricuspid valve also closes, and then just after that S1 heart sound, the aortic valve opens, and you get that rapid ejection phase followed by the reduced ejection phase. So what this tells you is that that S1 heart sound, or the lub, right? Lub dub, lub dub, lub dub. That lub is the actual sound of the mitral valve and the tricuspid valve closing. And if you think about how a heart is working, when the mitral and tricuspid valve closes, that tells you that you're starting systole. Because if the mitral and tricuspid valve close, then you're not filling the ventricle, but the ventricle is about to squeeze and eject the blood that's already been filled out through the circuit, right? Think about it. Why would the mitral and tricuspid valve be closed? Because we're about to start systole. So the S1, or the lub, is the sound that the mitral and tricuspid valves make when they close. Now the S2 sound, or the dub, let's go back to our cardiac cycle here. The S2 sound, or the dub, happens just at the beginning of diastole. So that's when the isovolumetric relaxation phase occurs. And the S2 heart sound is the aortic and pulmonary valves closing. Okay, so lub is mitral and tricuspid closing. We're starting systole. Dub, or S2, is the aortic and pulmonic valves closing, and therefore we are starting diastole. So if we look at this graphically, we see lub followed by dub, S1 followed by S2. And between the S1 and S2 heart sound, we're in systole, because think about it. S1 means mitral and tricuspid valves close. We go through that isovolumetric contraction, followed by rapid ejection, followed by reduced ejection, and that whole stage, or those 3 steps that I just named, are during systole. And then we have the S2 sound, or the dub, where the aortic and pulmonic valves close. And therefore, when that happens, we enter the isovolumetric relaxation phase, followed by the rapid ventricular filling, followed by the reduced ventricular filling. And all of the stuff that I just mentioned occurs during diastole. So between S2 and between S1, or between the dub and the lub, we are in diastole. So it should make sense to you that depending on which heart sound you're hearing, you can actually figure out, where am I in the cardiac cycle? So this is our summary so far. The normal heart sound is S1 followed by S2, the lub followed by the dub, the closing of the mitral tricuspid followed by systole, followed by the closing of the aortic pulmonic, followed by diastole, and that entire cycle just runs on repeat. So now for the actual audio file, this is what normal heart sounds sound like. Now it's important to appreciate the sound you just heard, because normal heart sounds are normal. So if you know what normal sounds like, then you'll know what's not normal. And this is true of all of medicine. Whatever you're studying, learn what's normal first. This is why your first year of medical school, they teach you physiology, and your second year of medical school, they teach you pathology, because you don't know what's broken until you know what's normal. So now that we understand normal heart sounds, and we understand S1 and S2, and what's creating those sounds, and what those sounds represent, let's talk about splitting of heart sounds. So when we talk about splitting, what we're talking about is what happens to the S1 and S2 heart sound depending on how we're breathing and what different types of pathology we can have in the heart. Now, because the S1 heart sound is 2 valves closing and the S2 heart sound is 2 valves closing, technically the S2 could be rewritten as, instead of S2, it could be rewritten as A2 and P2, because since both the aortic and the pulmonic valves are closing roughly simultaneously, it's the 2 different valve closures collectively contributing to one sound. So although in normal hearts without splitting, you would hear them as one singular S2 or one singular dub, what's actually happening in microseconds is that there are 2 distinct sounds, and that dub is created from the closure of A and the closure of P. So that's the closure of the aortic and the pulmonic valve. So what can happen sometimes is that when certain pathologies get introduced in the heart, or somebody changes how they're breathing, A2 and P2 can actually separate. So that singular purple line representing A2 and that singular red line representing P2 can actually have some shifting. And depending on whether you're breathing in during inhalation or breathing out during exhalation, those lines can slide. Now I'm going to explain all the physiology here and what's happening, but let's start by talking about wide splitting of S2. So when you get splitting, A2 and P2 will separate. And then depending on, again, whether you're breathing in or out, those individual lines will separate more. So when you have your headphones on and you're listening to the audio file on your exam, or you have your stethoscope on a patient's chest, and the lub-dub doesn't sound like lub-dub, 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 but you hear lub-dub-dub, 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 lub dub dub. Now the dub is being separated or split. So this is why splitting is important. So when it comes to wide splitting of S2, let's talk about what's happening. So the cause of wide splitting of S2 is anything that delays right ventricle emptying. Now the two highest yield exams are going to be pulmonic stenosis and a right bundle branch block, so the RBBB. Now let's talk about this. So we can see here on the wide splitting graph that A2 and P2 separate, and then during inhalation, that P2 separates even more. So it gets split out even more widely. So let's just look at pulmonic stenosis as an example. So imagine that you are breathing in. So you got inspiration or inhalation. And when you breathe in, you take that deep breath in, there's a decreased intrathoracic pressure. Now what does this mean? When there's decreased intrathoracic pressure, you get an increase in right ventricle filling. You also get an increase in right ventricle ejection time and right ventricle stroke volume. So the net effect here is that we first drop our intrathoracic pressure, and that means more blood is going to flow down that gradient into the right ventricle. So if more blood is flowing down into the right ventricle, that means that the right ventricle will be squeezing out more flow through the pulmonic valve. So this is going to increase the capacity of our pulmonary circulation and decrease the impedance of our pulmonary circulation. Now, everything that I've just mentioned and everything that I've just summarized for you, I'm highlighting that in green here because that's normal splitting. We might call this physiologic splitting. So under normal circumstances, when somebody takes a breath in, and they have increased right ventricular return, which means increased right ventricular output, that is going to have a slight shift during inhalation only to space out that P2 heart sound more. Because since more blood will be flowing over the pulmonic valve, it will take longer for that pulmonic valve to close relative to the aortic valve. So A2 will happen first because the aortic valve is closing, since not as much blood is flowing over the aortic valve when we zoom in and look at these milliseconds. But for that pulmonic heart sound during inhalation specifically, because more blood is flowing over the valve, it will have delayed closure of the P2 valve. So when we look at this graphically, we'll see the lub, which is your S1, and then we'll see the dub. And we're splitting the dub into the aortic and pulmonic valves closing separately. Again, and I'm summarizing here to really drive this home, when you take a breath in, more blood goes to the right ventricle, which means more blood flows over the pulmonic valve, which means the pulmonic valve takes longer in milliseconds to close. So that P2 heart sound will get spaced out, and there'll be some normal splitting, but during inhalation especially, it'll get spaced out even more. So this is normal splitting, and I would summarize this by saying during inhalation, the pulmonic valve closure, or the P2 component of the dub, or the P2 component of the S2, gets normally or physiologically split, so it spaces out. Wide splitting occurs when you get this during inhalation in the presence of pulmonic pathology. So basically, anything that causes slower or longer blood flow over the pulmonic valve already causes normal splitting. So introducing pathology such as pulmonic stenosis or a right bundle branch block will exaggerate an already exaggerated process, spacing this out even more during inhalation. So if we go back to our pulmonary stenosis example, under normal circumstances, when you take a deep breath in, you get increased right ventricular filling, stroke volume, and ejection time, increased flow over the pulmonic valve. But in the presence of pulmonic stenosis or a right bundle branch block, where in both of those conditions, it will already cause slower or longer or exaggerated flow over the pulmonic valve will take even longer to close, which means that when we look at a graph or a visual depiction of wide splitting, the A2 sound and the P2 sound will get spaced out, and during inhalation, the P2 sound will get spaced out even more. So I really hope that that makes sense. This is wide splitting, and this is how this works. Now that you understand wide splitting, let's look at our next example of splitting. So now we'll talk about fixed splitting of S2. So in fixed splitting, the A2 and P2 components of the S2, or those two separate components of the dub, they get spaced out, but during exhalation and inhalation, it's fixed. So you're not going to get that red line separating like we saw in wide splitting. It's going to stay one line that during exhalation and inhalation, it's going to be equal no matter what. So let's talk about what causes fixed splitting. So the classic example of fixed splitting is a left to right shunt, which you'll classically hear in an atrial septal defect, or an ASD. And the reason that this is fixed is because it doesn't change with inhalation. And let me just explain what's going on here. So let's say we have an atrial septal defect. Again, person takes a breath in, you get a venous return that increases to the right ventricle. Now, under normal circumstances, that increase in right ventricular filling will attempt to overfill the right ventricle, and it will attempt to put more blood through the pulmonary system like we just talked about in wide splitting. But we've got an atrial septal defect. So we've got a left to right shunt that's actually fixing the volume that the right ventricle can accept. Because think about it, even if theoretically the right ventricle was going to accept more blood and pump more blood, where would that blood be going? It would be flowing through to the left side of the heart, but because the atrial septal defect is present, all of the blood in the left side of the heart would actually get shunted back to the right side of the heart. So even if for a split second that right ventricle could put more blood through the pulmonic valve and cause a delayed pulmonic valve closure, it wouldn't really matter what you did or what the patient did during inhalation or exhalation, because eventually you're going to get equilibration between the left and right side of the heart because that atrial septal defect is there, allowing that hole to pass blood and shunt blood from the left to the right side of the heart. So in a split second, you might get more flow through the pulmonic valve, but over time, and when you're listening to a patient with a stethoscope and when you're visually depicting splitting visually on your exams, you're not going to see any difference because that ASD is going to allow that blood to flow right back and you're going to get quick equilibration. So again, no change in pulmonic closure during inhalation or exhalation because that ASD is open and it's basically shunting and equilibrating the left and right sides of the heart. So it doesn't matter what happens during inhalation or exhalation, those lines are going to be equal. And again, if we go back to this graph here, this is what fixed splitting looks like. When you breathe in, when you breathe out, that P2 doesn't move. It's going to be separated from A2, but it's going to be equal. It's not going to move during inhalation or exhalation. So if you see this visual depiction, we're talking about fixed splitting of S2, and you want to think about a left to right shunt. Because again, physiologically, under what circumstances would breathing in not cause more blood being pumped from the right ventricle through the pulmonary circuit? There would have to be a shunt. If you see this, think ASD. So that is your atrial septal defect. It's a little tricky, but I think that if you understand what an atrial septal defect is, it makes a lot of sense. Now let's talk about the most confusing splitting of S2, and that's paradoxical splitting. And this really throws medical students for a loop, so I'm probably going to over-explain this so that you really hammer this home. So paradoxical splitting is caused by anything that causes delayed aortic valve closure. And the classic examples on your test will be either aortic stenosis or a left bundle branch block. So let's look at our graph here. What we see is we've got our S1 or our lub followed by what's normally our S2 or our dub. Now in all the other graphs, you've seen the A2 or aortic component of the dub happen first. And then you saw the pulmonic or P2 component of the dub happen second. But in paradoxical splitting, that actually gets reversed. So let's talk about that. So let's use aortic stenosis as our example. So recall that normally we've got our A2 component right before our P2 component. So I'm talking about the two different S2 subcomponents, the dub. Usually it's A2 before P2. Okay, so normally it's A2 before P2, but in the presence of pathology of the aortic valve, which causes a delayed closure of the aortic valve, it means that the aortic valve will take longer to close than the pulmonic valve. So that A2 and P2 subcomponent actually get flipped. So now it's the pulmonic valve that closes first because you've got aortic stenosis. So more blood flow or longer time of blood flow over the aortic valve delays the closure of the aortic valve, so it delays the A2 subcomponent of the S2 dub. So that's what would happen in aortic stenosis. But let's say that a patient takes a deep breath in, right? They do inhalation/inspiration. What's happening now? So now they take a breath in, more blood flows to the right ventricle because we have that drop in intrathoracic pressure. More blood flows over the P2 or the pulmonic valve, which means that the P2 component takes longer to close, because just like we saw in our original discussion of physiologic splitting and wide splitting, when you take that breath in, more blood to right ventricle, more right ventricle ejection, more right ventricle ejection time, more blood flowing over pulmonic, takes longer for the P2 subcomponent of the S2 dub. So what does this mean or look like? What does this look like on the graph? Well, when you take that breath in, the P2 sound should be happening earlier, but when someone has aortic stenosis and when someone breathes in, the P2 component actually slides closer back toward the A2 sound. So the reason that this is called paradoxical is that you're supposed to hear pulmonic first and aortic second, because aortic is actually stenotic. But when you take a breath in, you're renormalizing them. So you're sliding pulmonic back towards A2. And A2 is delayed, right? A2 is stenotic. It's taking longer for the aortic valve to close. That aortic heart sound, or that A2 subcomponent, should happen second. But if you take a breath in, then the pulmonic sound is delayed as well. So taking the breath in makes what should be a reverse split paradoxically come back together and sound more normal. So this is why medical students get confused. It's paradoxical because you're supposed to hear a reversal, but when you take a deep breath in, it renormalizes what should be reverse order. That's why it's called paradoxical. So after I explained it, I think it makes a lot more sense, but let's do a summary slide. So here is normal, wide, fixed, and paradoxical splitting and what they're associated with. So normal is just the physiological effects of taking a breath in. Wide splitting is associated with both pulmonic stenosis and a right bundle branch block. Fixed splitting is associated with that left to right shunt, so your atrial septal defect. Remember that if you see the P2 component of the S2 not changing with a breath in or a breath out, that has to be due to a left to right shunt. And then paradoxical is associated with any condition that delays the aortic valve closure. That's paradoxical because then you're taking a breath in and renormalizing what should be reversed to begin with. So the way that I remember this is wide, pulmonic, right, fixed, atrial, paradoxical, aortic, left. So I think wiper, first aid, PAL. Wiper, first aid, PAL. And those are my stupid mnemonics. Wiper, W for wide, P for pulmonic, R for right. First aid, F for fixed, A for atrial. And then PAL, P for paradoxical, A for aortic, and L for left. So if you remember wiper, first aid, PAL, wiper, first aid, PAL, then if you get a question on splitting and you can't quite remember the associations, knowing those silly, very simple sounding mnemonics can actually pick you up a free point. Now, this is my summary chart, but the big takeaway from this section of the video is physiologically what's actually happening here. Because if you understand the in-depth explanation of where the blood is flowing through the heart, which valves are taking longer to close, and what happens when we take a breath in, this should make perfect sense. So I hope that you understand this. I know that I really beat a dead horse here and probably over-explained this, but it's my experience that medical students don't get an explanation like this. So they're stuck just kind of like memorizing what they see in first aid and what they hear in their in-class lectures. But those explanations have historically been awful. So hope this was useful. This is splitting of S2 heart sounds. So at this point in the video, we've now talked about what normal heart sounds are, what they look like, and what they sound like. And then I went into a very long-winded explanation of the different types of S1, S2 splitting. And if you're comfortable with this conversation so far, let's transition now and talk about some of the main high-yield pathological murmurs. We're going to run through these one at a time. We'll start with aortic stenosis. And as you can see on this slide, how I want to approach this is to keep it stupid and simple. So we'll do a description of what the murmur is reported to sound like. We'll talk about clinical associations, and then we'll list out that visual depiction of what the amplitude of sound looks like, and I'll give you the audio file as well. Now, this is important because when we talk about description and clinical associations, this is the stuff that shows up in the exam questions. So in USMLE and COMLEX, if they're going to give you buzzwords or phrases or describe the murmur to you, you want to know the description and the clinical associations so that when you see aortic stenosis, you think, oh, I have to think about this association. So if you see that association, you can work backwards and get aortic stenosis. Basically, the idea here is I want to give you guys a lot of different neural networks to connect in your brain so that you're getting these concept maps and you're generating ways to think about these questions in a high-yield way. So let's start with aortic stenosis. Aortic stenosis is described as a systolic crescendo-decrescendo ejection murmur. So a couple important things here. One, it's systolic. So it has to be occurring between S1 and S2, between the lub and the dub. Because remember, between those two sounds is where systole occurs. Now, it's described as being crescendo-decrescendo. And if you look down at the bottom of the slide, at the visual depiction, crescendo-decrescendo means that the sound peaks and then it drops off. So it gets louder and then it gets softer. It gets louder and then it gets softer. And that style of the sound being harsh and during systole cues you that you should be hearing and thinking about aortic stenosis. Now, the associations of aortic stenosis, there are a few. The first one is called pulsus parvus et tardus, which is a fancy way of saying that there is a weak and delayed carotid upstroke. Now, on clinical exam, you can actually palpate somebody's carotid upstroke. And if they have aortic stenosis, because the aortic valve is stenotic and therefore blood will flow through that aortic valve more slowly and over a prolonged period of time, the blood that would be flowing into the carotids is weak and delayed. So if you're looking at the carotid upstroke, it shouldn't surprise you that in the presence of aortic stenosis, that upstroke will be weak and delayed. And that is what pulsus parvus et tardus refers to. Now, as far as symptomatic-wise, patients might experience syncope, angina, and dyspnea. And again, think about it, guys. The aortic valve is stenotic, so they're going to have trouble catching their breath because you're going to get some backflow. This is usually associated with aortic regurgitation. So you're going to get some backflow through the pulmonary circuit, so you're going to get dyspnea. You're going to have syncope because the aortic valve is stenotic, so it's difficult to have an ejection fraction that's going through that valve that's supplying blood to the brain in an adequate fashion. And there's going to be angina because over time you're going to get left ventricular remodeling as the heart works harder and harder to pump through that stenotic valve. Now, the other thing that's not listed on this slide that I just want to point out is a little bit about etiology. So usually, the most common cause of aortic stenosis is what we call aortic valve sclerosis, and that's usually due to age-related calcification. So over time, little calcium deposits will go around the valve, and then that valve will become stiff and fibrotic, and the aortic valve leaflets will not function like they used to. So if you get a test question, and this is more step 2, level 2, but if you get a test question that asks what is the most common cause of aortic stenosis, the answer is age-related calcification and fibrosis, better known collectively as aortic valve sclerosis. Now, the other thing you want to think about with aortic stenosis is if it's an older patient, it's usually safe to say that that's due to age-related calcification. But if a younger patient has aortic stenosis, you want to think about a bicuspid aortic valve. And a bicuspid aortic valve simply refers to when two of the aortic valve leaflets fuse. Usually that happens in utero. And if that happens, the person is obviously going to have dystrophic aortic valves. So they'll get a functional aortic stenosis because of that bicuspid aortic leaflet fusion. On USMLE and COMLEX, if you have a young patient who has aortic stenosis, I want you to think bicuspid aortic valve. And usually, but not always, on USMLE and COMLEX, the association with bicuspid aortic valve that you should think about is going to be Turner syndrome. So if you see a young patient with aortic stenosis, immediately think Turner syndrome, and then that will open up the door to all of the other clinical findings associated with Turner syndrome. So you can see that a test question could start with just giving you the audio file of aortic stenosis, tell you that it's a young patient, and then they're going to ask you something like, what other clinical sequelae could we see in this patient? And they're telling you it's Turner syndrome. So you got to think about all that other stuff that you see with Turner syndrome. The last thing I want to say about aortic stenosis before we get into the audio file is you also want to think about rheumatic fever. So if you're in the US, you probably don't associate aortic stenosis with rheumatic fever. This is a higher income country, and there has been consistent eradication and monitoring and treatment of strep pharyngitis. But in lower income countries, there is still a pretty significant association between aortic stenosis and rheumatic fever. And where treatment is perhaps not as available, not as widespread, you can see the complications of rheumatic fever, one of which would be aortic stenosis. So that's aortic stenosis. Takeaway from this slide is crescendo decrescendo occurs during systole, is very harsh sounding. You see pulsus parvus et tardus, syncope angina dyspnea. So people say that aortic stenosis makes them sad, SAD, syncope angina dyspnea. And remember that in an older person, it's usually due to calcification. In a younger person, think bicuspid aortic valve, think Turner syndrome. So now with that said, what you want to listen to when you hear an audio file is look for that first initial loud sound and then that second drop off. So in just a second, I'll play for you what aortic stenosis sounds like. And I want you to really appreciate that although it's faint, it's very harsh sounding, and the first part of the sound is louder. The second part of the sound drops off. So that first part is crescendo, that second part is decrescendo, and it occurs between the lub and the dub, or between S1 and S2, so we know that it must be aortic stenosis. So this is what aortic stenosis sounds like. All right, so I hope you were able to appreciate the crescendo part at first, and then the decrescendo part following that, but that's aortic stenosis. All right, so we've now talked about aortic stenosis, and let's move on to mitral and tricuspid regurgitation. So mitral and tricuspid regurgitation get grouped together when we talk about heart murmurs because they both sound identical. So the only difference between how you pick up whether you're listening to mitral or tricuspid regurgitation is where the stethoscope is placed, either on a real live patient's chest or on your exam where the stethoscope is in the visual simulation of the patient. So these are both described as holosystolic, high-pitched blowing murmurs. Holosystolic, holo, all, systolic, systole. So this happens continuously throughout all of systole. And if you look down at the bottom of the slide at the visual depiction, the amplitude of sound doesn't change. So the volume is going to be roughly the same throughout the entire murmur. Now, the clinical associations, it really depends on whether we're talking about mitral or tricuspid regurgitation. So for mitral regurgitation, you want to think about some type of degenerative heart process where you get direct rupture of the chorda tympani. So that could be like post-myocardial infarction. It could be due to chronic remodeling of the left ventricle, resulting in left ventricle dilatation and then subsequent rupture. It can be a whole host of different things. But usually for mitral regurgitation, you want to think of structural and ischemic heart disease. You can also see it in infective endocarditis and, like I said, ischemic heart disease. For tricuspid regurgitation, you want to think about the causes of right-sided heart failure. So classically, you want to associate this with intravenous drug abuse because, again, as pathogens, and I've said this in other videos, but again, as pathogens pass over the tricuspid valve, they're going to preferentially damage the tricuspid valve before the body figures out a way to filter them out. So you get preferential right-sided heart failure in the setting of intravenous drug abuse. Also think about Marfan syndrome, carcinoid syndrome, and pulmonary hypertension as other high-yield things to associate with right-sided heart failure, more specifically tricuspid regurgitation. Of note, rheumatic fever can cause either mitral or tricuspid regurgitation. And when you're listening to this sound on exams, the only way you're going to know whether it's mitral or tricuspid, either the clinical vignette will hint heavily at an association. So if they say the chorda tympani was ruptured, then you want to think mitral. If they say the person has a 20-year history of shooting heroin, then you want to think tricuspid. But otherwise, really the only way to get this is where's the stethoscope? So if the stethoscope is at the apex and the sound is described to radiate toward the axilla, that's mitral. But if the stethoscope is at the tricuspid area, then that's obviously tricuspid. So other than that, there's really no other way to delineate whether you're talking about mitral or tricuspid, because both of them are holosystolic, high-pitched blowing murmurs that sound identical and last for all of systole between the S1, S2 heart sound. So looking at our visual depiction, when your headphones are on, this is going to be holosystolic, high-pitched, blowing, and continuous from S1 to S2. So put your headphones on and listen, because this is what mitral and tricuspid regurgitation sound like. All right, so I hope you can appreciate that murmur goes continuously and is high-pitched and blowing between the S1 lub and the S2 dub. So that's mitral and tricuspid regurgitation. So here's what we've covered so far, and we're making really good progress, so just bear with me, everybody, as we keep the momentum going. Now let's talk about mitral valve prolapse. So mitral valve prolapse is classically described as a late systolic crescendo murmur that has a mid-systolic click. And that description, that buzzword, the mid-systolic click, is so unique to mitral valve prolapse that if you get either the audio file of this murmur on your exam, or you get the amplitude waves, which you see visually at the bottom of this slide on your exam, you really should get this free point because it's incredibly unique. Now, usually mitral valve prolapse is asymptomatic in a lot of patients, but of course you're taking USMLE and Comlex, so chances are if the test writer wants you to think or pick mitral valve prolapse, they're actually going to give you somebody who's symptomatic. So for the associations, you want to know that mitral valve prolapse is heavily associated with connective tissue disorders like Ehlers-Danlos syndrome and Marfan syndrome. It's also associated with less common presentations, which would include osteogenesis imperfecta, Fragile X syndrome, and autosomal dominant polycystic kidney disease, but the huge or high-yield genetic associations are definitely those connective tissue disorders. You also want to associate mitral valve prolapse with rheumatic heart disease and infective endocarditis. Now, what's happening here is actually really interesting, and I'm just going to take a moment to explain the pathophysiology. Now, in these connective tissue disorders, you have the abnormal deposition of different substances. You've heard me talk in other videos about what happens in these connective tissue disorders, but the same thing that you see elsewhere in the body, you also see in the heart. So in the case of Ehlers-Danlos syndrome and Marfan syndrome, you get the deposition of different types of substances such as dermatan sulfate, etc., onto the mitral valve directly. And what happens here is that all of this excess and abnormal deposition of this material creates this elongated, fat, floppy, dysfunctional mitral valve leaflet. And when the mitral valve can't function the way that it's supposed to, it kind of bulges through, and hence the name mitral valve prolapse, into the left atrium during systole. So while mitral valve prolapse initially starts as its own unique valvular disorder, eventually what happens over time is mitral valve prolapse actually leads to mitral regurgitation, because as those leaflets just kind of bulge into the left atrium, which over time leads to papillary muscle dysfunction, ischemia, and possible rupture of the chorda tendineae, you actually get the onset of severe mitral regurgitation. So if you're taking your exam, they could give you mitral valve prolapse and then ask you which of the following other murmurs is this patient likely to experience in the future? And the answer would be mitral regurgitation. So That's the association with mitral valve prolapse. That's a little snippet of the pathophysiology. Again, if I were to summarize that complex picture, I would say that there's deposition of substances such as dermatan sulfate and other glycosaminoglycans, which cause the mitral valve leaflets to be floppy and fat and not work, bulge into the left atrium, and then downstream create mild to severe mitral regurgitation because those leaflets just can't function like they're supposed to. Now look at the bottom of this slide and look at the visual depiction of what this murmur looks like. You're going to hear the audio file in just a second, but basically when you're listening with your headphones on, you want to try to appreciate that mid-systolic click. And this is a late systolic crescendo murmur, which means that for the first half of the heart sound, between the lub, between S1 and the onset of that mid-systolic click, you really don't hear anything. So it's like a brief millisecond or so of silence. And then you hear the mid-systolic click, and then from that mid-systolic click to the S2 dub, then you hear a gradual increase in volume for the remainder of systole. So hearing that click is so unique to mitral valve prolapse that if you hear that, this is the answer. Now, I have another video where I go through all of my different mnemonics for how you memorize the description of the murmurs. So for example, for MVP, it's the mid-systolic click. And I'm going to reuse one of my mnemonics here because it's so helpful. So when I think of mitral valve prolapse, I think of MVP, which classically to me means most valuable player, and that I use that in the context of sports. So if you want to be the MVP, your team has to click. And that reminds me that mitral valve prolapse is associated with this mid-systolic click. So when your headphones are on, if you hear that click, your team has to click, you're the MVP, mitral valve prolapse. So when we listen to mitral valve prolapse, we really need to pick up on that late systolic crescendo murmur with the mid-systolic click. So I'm going to play that for you now. This is what mitral valve prolapse sounds like. All right, so I hope you were able to pick up on the fact that it's pretty silent between the S1 and the click, and then once you hear the click, you get a gradual increase in volume until the S2. If that's difficult for you to pick up, I want you to close your eyes and see this visual wave amplitude while you listen to the sound and really follow that with your eyes and your ears. Connecting these two is huge, but that's mitral valve prolapse. All right, so here's where we are. I am super proud of everybody. You are making incredible progress learning what is obviously the most difficult section of cardiology to learn. Let's keep this rolling by talking about actually an easier murmur to learn, ventricular septal defects. So VSDs are described as holosystolic harsh murmurs. And if we just jump ahead and look at that visual depiction of the wave amplitude of this murmur, you can see that this looks almost identical to tricuspid and mitral regurgitation. And that's because just like those other murmurs that we've already talked about, this is also holosystolic. The associations with ventricular septal defects are a lot of your genetic abnormalities. So we're talking about Down syndrome, Edwards syndrome, and Patau syndrome. You can also look for associations with your various torch infections. So we're talking about toxoplasmosis. The O stands for other, which is varicella and parvo B19, rubella, CMV, herpes, HIV, and syphilis. You also can see less commonly an association with Cry-Ducot syndrome. Recall that is the disease that is due to a problem on chromosome 5, and that's where your patients will present with intellectual disability, some other congenital skeletal abnormalities, and then that classic cat-like high-pitched cry/scream. But really the big thing about ventricular septal defects that you need to understand is that these are just holosystolic harsh murmurs. And on a test, you might be thinking, well, how am I going to differentiate this from tricuspid or mitral regurgitation? And I have two answers. The first is that ventricular septal defects are harsher sounding and not as high pitched as the other two that we already talked about, which are also holosystolic. So if you're really stuck and there's no other clues in the vignette, whichever one sounds harsher, which is like more disorganized and ruffled, that's what you want to pick for the VSD. And if you think that it sounds high-pitched and it's also holosystolic, then that pushes you more in the direction of tricuspid or mitral regurgitation. But really where the clues will come in is in the vignette. There'll be other buzzwords or diseases or genetic statements that will give you an association. So you want to know what's associated with ventricular septal defects, because if they describe a patient that might have Down syndrome, then obviously you hearing a holosystolic murmur should make you think VSD. So ventricular septal defects are really not that complex in terms of what you need to know. I would just encourage you to know what happens in Down syndrome, Edwards syndrome, and Patel syndrome. And if you see any of those clinical sequelae or clinical features and you hear a holosystolic murmur, guess ventricular septal defect, so that you're not in a position where you're like, is this harsh? Is this high-pitched? I wish that the testing center gave me better headphones than these $4 sets of headphones that have been worn by thousands of people. And I'm probably going to get otitis because they're disgusting. But anyway, that's ventricular septal defect. Not a whole lot to know, like I said. And when it comes to picking up what this sounds like, it's going to be holosystolic and harsh. So this is what a ventricular septal defect sounds like. All right, so as you can probably appreciate, it's holosystolic, so it goes throughout all of systole between the S1 lub and the S2 dub. The sound is from S1 to S2 with no breaks or interruptions in between. It's kind of harsh sounding, and if you rewind the video and you go back to the MRTR, this is harsher sounding and not as high pitched, and that's the really subtle difference. But again, just know the associations, because the test writer has to give you some clue to differentiate this from the ones we've already talked about. All right, so now let's talk about aortic regurgitation. And aortic regurgitation will actually be the first diastolic murmur that we'll talk about. This is described as a high-pitched, blowing, early diastolic decrescendo murmur. So if you jump down to the bottom of this slide and look at the amplitude waveform, what you'll notice is, one, it's diastolic, and two is that not only is it diastolic, but it's decrescendo. So right after that S2 dub, this murmur will start off loud, but then it will kind of gradually taper down. And that's what the decrescendo part refers to. So when you have your headphones on, and we'll get to that sound in a few moments, you'll hear it blowing and it'll be louder right after the S2 and then kind of taper off before you hear the S1. Now, when you associate aortic regurgitation, you want to associate it with a few things. And it really depends on if we're talking about an acute aortic regurgitation or a chronic one. Acutely, you want to think infective endocarditis, but more chronically, you want to think about things that alter the structural integrity of the aortic valve. This should make sense. If it's just an acute problem, it's something temporary, like an infection, like infective endocarditis. And ideally, we would like to think about infective endocarditis as being treatable, so it only causes an acute or temporary aortic regurgitation. But chronically, this is going to be due to the integrity of the aortic valve being lost completely, usually due to some type of congenital or structural abnormality. And that's why in chronic aortic regurgitation, you associate it with things like bicuspid aortic valve and some connective tissue diseases. Now, you see this picture of an orange hammer here on the slide, and the reason that I put that there is because one of the biggest buzzwords or biggest descriptions or just high-yield snippets that the test writer will give you either on USMLE, COMLEX, or your in-class exams is what's known as a water hammer pulse. Now, a water hammer pulse refers to a widened pulse pressure in aortic regurgitation, and you see this thing called the water hammer pulse as a physical exam finding. So what this is that because of aortic regurgitation, there is an increased stroke volume every time the left ventricle does its systolic stroke. And as you could imagine, with aortic regurgitation, that blood flowing retrograde back through the aortic valve causes an increased end diastolic volume in the left ventricle, What this means is that every time the left ventricle squeezes, it's squeezing out what was previously an increased end diastolic volume. So the systolic part and the volume of blood that the left ventricle squeezes is really increased because of the aortic regurgitation. Now, what happens is when you look at that on physical exam, you see this rapid rising of the pulse, right? You see this rapid rising whenever the heart is squeezing out that increased end diastolic volume. But the second part that makes the water hammer pulse such a unique finding is that then in the diastolic phase, there's a rapid collapse. So just as big as there was that pulse going up and increasing with that extra large stroke volume, that's also mirrored by the rapid collapse during diastole. And what's happening there in diastole is that because blood is regurgitating back from the aorta back into the left ventricle, there's a very rapid, what we call aortic runoff. So normally that blood, that diastolic pressure would not collapse as quickly. But again, it's aortic regurgitation, guys and girls, which means that there's retrograde flow. So that retrograde flow happens more rapidly backwards. And then in addition to that, the arterial system, just generally speaking, empties more rapidly. And this is a change over time due to some remodeling of the arterial system in the setting of aortic regurgitation. But if I were to summarize the water hammer pulse, what I would say is that it's due to an increased stroke volume because of an increase in end diastolic volume due to retrograde blood flow back over the aortic valve. So you see a rapid upstroke of the pulse followed by a rapid collapse due to, again, aortic runoff where that blood flows back over the aortic valve. So what I just described is a little bit long-winded, but if you can imagine that and you were with me on what was happening and why stroke volume was increased, but then why the diastolic section or the diastolic part was just like rapidly collapsing, then you're in good shape because this is bound to show up on exams. If they're pointing you in the direction of aortic regurgitation, they either have to describe that finding that I just gave you, or they have to give you the murmur either visually or acoustically, and you've got to pick it up. Now, before we get to the murmur sound, there is one other somewhat high yield association clinically that I want to point out. And you might see in your test question what's called head bobbing. Head bobbing is also known as de Musset sign. I'm probably butchering the pronunciation of the person's name, but it's DE space MUSSET, de Musset or de Musset. And what this is that it's just head bobbing. So the de Musset sign is basically the patient will be bobbing their head, which will synchronize with the beating of their heart. And this was observed way back in the day, which is why this is not really high yield. It's just sort of an incidental thing that some patients have. But because the pulse pressure is so widened due to the aortic regurgitation, patients actually feel the systolic pulse. So they feel that huge excess stroke volume that's trying to squeeze out all of that blood that gets retrograded, if that's a word, back into the left ventricle. So with every stroke, there's such a high volume of blood coming out due to the regurgitation that patients actually feel it. And in synchrony with that stroke, they'll bob their head. And this is called de Musset sign. So if you're taking an exam and you see either the water hammer pulse where that, the rapid upstroke and that rapid collapse, or head bobbing, the test writer is telling you, yo dude, hey lady, it's aortic regurgitation. Now let's go down to the wave amplitude and listen to the sound here. So again, this is an early diastolic decrescendo murmur that's described as high-pitched and blowing. So this is what aortic regurgitation sounds like. All right, so as you can hear, you hear the S2 dub, then you hear the onset of the high-pitched blowing murmur, and it gets softer over time until we get back to the S1 lub. And then during systole, there's silence because this is a diastolic murmur. So that's aortic regurgitation. So here's where we are. You guys are doing amazing, great progress. There's really only one more murmur to learn, and that's mitral stenosis, because patent ductus arteriosus is pretty easy. So I only need your attention for a little while longer. Mitral stenosis is referred to as a diastolic opening snap, which is followed with a delayed diastolic rumbling. So you look at the bottom of this slide, you see in the waveform that orange highlighted line, that's the opening snap. And then there's sort of this decrescendo style, slightly diminishing diastolic rumbling that becomes a little bit louder in the later stage of diastole just before the S1 lub. But the opening snap happens after the S2 dub. And then there's a little bit of a delay between S2, the dub, and where you hear the opening snap. Now, as far as associations go, you want to think when it comes to mitral stenosis about rheumatic fever. That's going to be the big one. Alternatively, and less commonly on USMLE and Comlex, you want to be on the lookout for patients with some types of rheumatological diseases. So lupus and rheumatoid arthritis can also give rise to mitral stenosis. But for some reason, test writers love to go after the things that functionally mimic mitral stenosis. So you see on this slide, I've written mimickers, and those include both a left atrial myxoma, so that's like tumor growth in the left atrium, as well as bacterial endocarditis, which is directly due to the growth of those vegetations on the mitral valve. And I just want to illustrate this because this does show up so often on USMLE and Comlex, that imagine you're looking down through the mitral valve, and this is the opening that you see. Under normal circumstances, this is the nice patent open valve where, again, we're looking down through into the left ventricle. But in the case of bacterial endocarditis, now let's imagine we have growth of bacterial vegetations. Because these vegetations are just chilling on the valve, functionally, the amount of open space that the mitral area has is now reduced. So although there's technically not a mitral stenosis, functionally, the effect on the heart is identical. There's reduced volume or reduced space through which the blood can flow from the left atrium into the left ventricle. So this is functionally a mimicker of mitral stenosis. Likewise, if we do another example, imagine the growth of a tumor in the left atrium. You've got this big, juicy left atrial myxoma, and then once again, we have a reduction in the functional space available for which blood can flow through the left atrium into the left ventricle, again, mimicking mitral stenosis. But what you really want to think about with mitral stenosis is what does it sound like and what does the waveform look like? And this is another really unique murmur because of that opening snap. That opening snap is so unique to mitral stenosis that it's a test favorite to just give you the audio file and force you to work backwards, either directly asking you which of the following murmurs does this sound correspond to, or asking you for the associations. But it all would start with the audio file. So in another video, I have a very high-yield buzzword, high-yield mnemonics that I lay out for associating mitral stenosis with opening snap. But just to use that mnemonic again here, because we're obviously talking about mitral stenosis, when I think mitral stenosis, I think MS. And when I think MS, I think OS for opening snap. And the mnemonic here is that the operating system is Microsoft. So the OS equals MS. The operating system equals Microsoft. And the OS being opening snap equals MS being mitral stenosis. So you absolutely need to know if you see the buzzword opening snap, they're talking about mitral stenosis. Now I'm going to play the audio file for you now. So this is what mitral stenosis sounds like. All right, so I hope you're able to appreciate the S2 dub, a little bit of a micro delay, and then you hear the opening snap followed by the decrescendo, and then later a little bit of crescendo, delayed diastolic rumbling. Now, what I want to do just briefly before we wrap up mitral stenosis is just talk about pathophysiology here and why you hear an opening snap. Because I'm a big believer in that if you understand the pathophys, this topic, which would otherwise just be super vague and confusing, makes a lot more sense because we're putting things in the context of physiology. So the reason that you hear an opening snap in mitral stenosis is that snap is the sound of the opening of the mitral valve. So I want you to close your eyes and sort of imagine this as I describe it to you. So the mitral valve, which in this case is stenotic, will open when the pressure in the left atrium exceeds the pressure in the left ventricle. And when that happens, we're in ventricular diastole. So in ventricular diastole, the pressure within the left ventricle drops. And as you should know at this stage in your medical education, blood, or any liquid really, wants to flow from high pressure to low pressure. So it wants to flow from the left atrium, which is higher pressure, into the left ventricle, which is in ventricular diastole, which is lower pressure. Now, because the mitral valve is stenotic, it's not going to open up until the pressure in the left atrium greatly exceeds the pressure in the left ventricle. And because the valve is stenotic to begin with, there's going to be even more pressure in the left atrium, because imagine trying to squirt blood from the left atrium into the left ventricle, but the lumen, or the area within the mitral valve, which in this case is stenotic, is decreased. So the circle, the lumen, the space through which you could push that blood, is thinner and thinner and thinner. So there's sort of like a backlog of pressure going into the left atrium. And this is really high yield to understand, because as the severity of the stenotic mitral valve gets worse, or as that lumen closes up even more, the pressure in the left atrium is only going to increase. So when that pressure increases and it shoots open the mitral valve to pop it open and send that blood from the left atrium into the left ventricle, you hear that forceful opening snap. And then the reason that it's a little bit decrescendo is because once it snaps open, now blood can flow and it can sort of equalize pressure for a little bit. So that opening snap corresponds to the opening of the mitral valve, which again happens when the increased pressure in the left atrium snaps open the mitral valve. But the truth is that if you understand pathophysiology, this makes just infinitely more sense. So that's mitral stenosis. All right, and to wrap things up, last but certainly not least, we have patent ductus arteriosus. So I'm not going to play the sound for this one because this soundbite rarely shows up on exams. Usually, if test writers want to go after patent ductus arteriosus, they're going to do it with buzzwords, descriptions, and associations. So patent ductus arteriosus is described as a continuous machine-like murmur. So because this is obviously a structural defect in the heart, you could expect that the murmur is continuous. It doesn't matter if the heart is in systole or diastole. And for that reason, if you look down at the waveform, you see that the murmur, which is described to sound like a machine, is going to be taking place during both systole and diastole. The highest yield part of patent ductus arteriosus is knowing the associations. So the big high yield associations, number one, you want to think congenital rubella. But then after that, you also want to think about any infant that's born prematurely. Now, usually, but not always, this will be due to either fetal alcohol syndrome or fetal Hayden-Towen syndrome. And just recall that fetal Hayden-Towen syndrome, that term, it's really an umbrella term that refers to a bunch of congenital defects that happen in response to something like phenytoin use, which is an anti-seizure drug. So anything that causes premature infancy can cause a PDA, but classically on exams, it's either fetal Hayden-Towen syndrome or fetal alcohol syndrome. Rarely it could be due to the trisomy, so you want to remember that Down syndrome can and other associated trisomies can also cause a PDA. But again, no congenital rubella and no your premature congenital diseases. The last thing that I'll say, just to touch on it, you've probably seen it 1,000 times already, but the treatment of a PDA, so it depends on if you want to keep it open or not. So if you want to keep it open, you would give prostaglandins, because prostaglandins will keep the patent ductus arteriosus open if the infant that has the patent ductus arteriosus needs surgical correction, but it can't take place yet. And that would happen in situations where you have something like a hypoplastic left heart or transposition of the vessels. In those situations, you do want to keep it open generally until you can get the infant the surgical correction it needs. But you could also close the patent ductus arteriosus. And if prostaglandins keep it open, then to close it, you would be giving something like indomethacin, which just acts exactly the opposite. So for patent ductus arteriosus, I kind of hinted at this when we were talking about mitral stenosis, but it's kind of easy. Continuous machine-like murmur. It's the only murmur that they'll give you in the audio file that will be in both systole and diastole. So for that reason, I'm not going to put the file here. It's pretty easy to pick up. If you hear it between the lubs and the dubs and then it just keeps cycling, it's a patent ductus arteriosus. Keep your eye open for congenital rubella and other premature conditions like fetal alcohol syndrome and fetal Hayden-Towen syndrome. That's it. This is a very, very long video, but it's a tough topic, and it was honestly hard to collapse this into digestible bits of information. But you're now an expert on splitting and heart sounds. Good luck.